All right, for the sake of time, why don't we get started? It's been a little bit of a hiatus over the summer and some technical issues, but it's nice to be back with our what will be hopefully a quarterly Boston Lymphatic Center webinar for lymphatic therapists. It's a great treat today to have Dr. Kevin Donahoe, who is a radiologist and specifically a nuclear radiologist, and maybe one of the more experienced people in the world with nuclear lymphoscintigraphy, which has traditionally been used as our go-to for diagnosis, but also now very helpful for preoperative assessment and postoperative assessment. He's also going to walk us through the variety of other diagnostic imaging modalities that we have available. And then Katrina and Kathy, two of our great therapists, will just have a little case discussion of how they use lymphatic imaging in their practice to optimize conservative care for patients. So with that, well, Kevin, why don't you take it away for us? Thanks so much for joining us.
All right. Well, thank you, Brett, and thank you for inviting me. Um, as Brett mentioned, I'm a nuclear medicine specialist. I've been at Beth Israel Deaconess for about 35 years, or more than 35 years now, and I think I'm starting to get the lay of the land. Um, and Several years ago, Drew Single joined our group, and it recruited me to help with the lymphoscintigraphy side of things for imaging lymphatics. And it's been a very fruitful and enjoyable experience for me, getting to know Drew and Brett and Kathy and Katrina and everybody else that's in the group. Um, so there are several different imaging modalities that we can use for imaging lymphatics, and they all have their strengths and weaknesses. ICG, indocyanine green, provides structural information about lymphatics, but mostly just superficial information. MRI, magnetic resonance imaging, great anatomic detail, and gives great information about tissue composition. When somebody has a swollen extremity, you're trying to figure out how much of it is fat, how much of it is fluid. MRI is fantastic for that. And it can also show the lymphatic channels with the MRI lymphangiography, but it's showing you the anatomy. It's not showing you the function of the channels as much. And then there's high frequency ultrasound. We use that a little bit for pre-surgical evaluation of patients. We want to, Drew is going to take them to the OR and wants to hook up a lymphatic channel with a vein. And you can use high frequency ultrasound to find tiny little lymphatic channels and find them adjacent to veins so that he knows what he can hook up. And then, of course, there's nuclear medicine, which is what my specialty is. And the nice thing about nukes is that it provides functional information. We put a tracer in the lymph, and we get to see that tracer flow through the lymphatics as it normally would, and go to the lymph nodes that it would normally go to. So indocyanine green is just a fluorescent dye that you inject. All the injection for both indocyanine green and for the nukes tracer, the lymphoscintigraphy tracer, are all done intradermally. And you want it intradermally because that's where you got a lot of lymphatic channels. There are larger channels below there, but it's more likely that the lymphatics are going channels are going to pick up the tracer if you inject it right by the capillaries, lymphatic capillaries. And when you do that, after you do that, you inject the tracer, then you shine a specific light on that tracer, specific wavelength light on that tracer, and then it causes the agent to fluoresce, and we can pick that up in a camera and get pictures of, like I say, the superficial lymphatics. We have we get a cine movie of it, and you can see, like here, there's just this blush of the dye, so it's not making it through the channels in an organized fashion. And so we can, after we get this map, then we can draw on the skin where we see these channels and get a nice map of how the drainage works in the skin. And like I say, if you see a big blush of activity where the linear channels stop, that's often signs of obstruction. And we can divide the ICG into different patterns into different terms. Linear pattern, of course, is what we like to see. A splash pattern is where it's diffusing a little bit. And stardust is you get a little bit of linear, but you get all these little spots in it. It's not really, you might be getting a little pooling of the tracer in little spots. And then diffuse pattern is just a blur, and you can't see any organization or anything, the tracer moving at all. And this is what linear channels look like, as I showed you. This is stardust diffuse. You've got kind of blobs of stuff here. So it's not really making it through this area very well. And then here's linear pattern. You see channel, everything's going up nice. And then you get to this stardust or this diffuse area. The advantages of ICG is it shows superficial lymphatics in detail, but once you get below about a centimeter or two, you can't see the channels very well. The optical light doesn't penetrate that deep, and it can be helpful for locating the site of obstruction. It doesn't have any ionizing radiation, which is we consider to be good, and relatively inexpensive equipment. Everything is expensive, but it's not as much as some equipment can be. It requires a fair amount of skill, and we have some very skilled technologists that do these injections and can massage the arm or the leg and follow the channels up and get an idea, and then map them out, draw them out, photograph them. Um, and it's not really physiological because the technologists, they're pushing and encouraging the stuff to go. It's not really what happens when the person doesn't have anybody massaging their arm. And it's also very time intensive. Getting the tracer to move, mapping out the areas drawn on the skin, getting it photographed, it can take hours for a patient, and but the information you get is very helpful. MRI, magnetic resonance imaging. Now we are getting into expensive equipment, and this is just a large magnet, and there are different coils that we can use. There are different parts of an MRI machine that you can put an extremity in, and we have MRI specialists that know a lot more about this than I do. But I don't want to get too technical here, but we've all got these protons in our body and they're spinning around and they're kind of lined up all sort of different ways. Well, when you put it in a big magnetic field, all those protons line up, and and uh, um, and you get them all pointing the same direction. And then you put in a radio pulse, and they get to relax. And what the MRI does is it senses that relaxation of the protons, and it gets the energy that's coming out of the body, and you get really nice images. You can change the sequence of imaging, so you're looking at different type parts of tissue. This is a fluid sequence where you can see like the white is fluid in the tissues, or then you can get a fat imaging sequence on the same person, and now you can see all the fat there, and we can look to see how much fat's there, how much fluid is there. You can also do MRI lymphangiography, and you get these gorgeous pictures of the lymphatic channels in the extremity, and you might say, well, why don't you just do that instead of the ICG or instead of lymphoscintigraphy? Well, it's not physiologic, so we can see these channels, but we don't know quite how much flow is going through them. And technically, this is very, very difficult to do. If you look in the textbooks, they'll show you pictures like this, but actually getting these pictures is very difficult. The tracer that is used leaks into the venous system, and now you're trying to figure out what's vein and what's lymphatic channels. And we have several people working on making nice, pretty lymphangiography pictures, but right now it's just not practical. It's technically very difficult to do. The advantage of MRI, it shows the tissue composition, fat, fluid, and we depend on MRI mostly for determining how much fat is there, how much fluid is there. If there's a lot of fluid, then we say, okay, you got to do more compression, you got to do more massage, that kind of thing to get the fluid out of there. If there's a lot of fat there, we may say, okay, now we're going to do some debulking. Gives great anatomic detail, as you can see, and there's no ionizing radiation exposure. The disadvantages, it's very expensive. And like I say, it's not physiologic. You're looking at anatomy, not so much flow of the agent through the vessels. And it's also a rapidly changing technology. It seems like every other week when the MRI radiologist comes in and talks to us, they're talking about different sequences and trying to image this way and that way. And I think it's just getting better all the time. And I suspect that it may end up being one of the primary imaging technologies that we use, but it's going to be a little while before that happens. And it requires very highly skilled operators. You've got to adjust a lot of adjustments to make. You got to know where to do the injection, what you're looking at, and obviously the equipment is expensive and it's very bulky. High frequency ultrasound is what we use for localizing veins and vessels. This is a vein, and then we can see if we can see a lymphatic vessel. This is the lower frequency, but with high frequency, now you can see the anatomic detail much better, and you can measure the distance between these two, and then we can talk to the surgeon and say, okay, this is close enough to anastomose this vessel to this vein. It obviously has no radiation. There's an expensive or exquisite anatomic detail, which is very nice. It's portable equipment, and I say it makes nuclear medicine images look good because, these are still fuzzy images. And nukes is always criticized that we're fuzzy, but ultrasound makes us look good. The disadvantages is it requires a lot of skill to know what to look for and how to look for it. You're moving a probe around on the skin, looking for these very tiny little structures. High frequency is not widely available now. It's getting to be more available, and it's time intensive. The radiologist can spend lots of time just slowly going over an extremity centimeter by centimeter trying to find vessels. And once you find it, can you find a lymphatic channel close to that kind of thing. So let's talk about lymphoscintigraphy, which of course is near and dear to my heart. We do the same kind of intradermal injection, and we inject a little colloid particle. It's a little kind of piece of protein, and it gets picked up with the other molecules in the lymphatics and taken to the lymphatic channels, just like normal lymphatic fluid would be. And we use a gamma camera for imaging at different intervals after you do it. Again, you want to do an intradermal injection where you're raising just a little wheal. It's like a TB skin test. This stuff can sting a bit, and it's to my chagrin that a lot of patients say that was I didn't like that at all. And we're trying to figure out how to make it less painful for our patients. And there are a couple options that we're looking at. And then this is a SPECT CT, another expensive piece of equipment. It's got a head that detects the gamma photons coming out from the tracer injection, and then a CT ring that we can do anatomic imaging, and then we fuse the gamma and the CT images together. It's another big machine. It's an expensive machine. It's a little more tolerated a little better by patients. And the radiation exposure is minimal. When we're doing some studies on normal subjects, and I tell them, we're talking about background levels of exposure. Even if you're living in Boston, you're getting radiation exposure just from cosmic and from the ground and that kind of thing. And this is a few times that exposure, so it's not a huge amount. We acquire images at different time intervals. We're looking at 30 minutes, 2 hours, and we get to see how well this stuff flows through the channels. We can see channels, we can see nodes, we can see dermal backflow. And this is what an image of the lower extremities might look like. You know, we inject down here in the feet, and then we see the channels leading up, and then here's a little stasis here. So at 30 minutes, you know, we don't see any lymph nodes over on the right side, but we do see them on the left side. So the left looks like more normal flow. And then at 2 hours, we see much more dermal backflow. This is that tracer getting congested. It can't find the vessels. It's getting stuck in the skin. But some is making it to lymph nodes over on that side. So we can note that and see that it's getting to the liver, which is what we want. We want to make sure it's getting out of the extremity. Like I say, we want to do intradermal injection. With dermal backflow, what you have is, instead of the tracer, or instead of the lymph coming out and going into the major vessels, it gets backed up, and it can't make it through the vessels, so it heads back up this way into the superficial lymphatics. And when looking at our normal subjects, some patients have lots of lymph nodes. These are lymph nodes superimposed over a skeleton. Some people just have a few lymph nodes. So there's huge amounts of variation in normal anatomy. And we're suspecting that that variation in normal anatomy may have something to do with who gets lymphedema after axillary node dissection and who doesn't get it. Then we can put it in a 3D image and spin it around and get an idea of what's going on. The advantage of lymphoscintigraphy, most physiologic study, we can see deep nodes, deep lymphatics. We can show location of draining nodes for, inject a certain site. You can see which nodes drain that site. There is some radiation exposure, but like I say, it's very small. We don't think we're doing anybody any harm. It's one of the lower level exposures that we do in diagnostic imaging. And we don't see the channels as well as we'd like. We don't have the anatomic detail that some of the other studies do. And so that's why you have to put all these different studies together to see the superficial channels with ICG, see the tissue composition with MRI, find the anatomy for anastomosis with the ultrasound, and then use the lymphoscintigraphy to see which nodes drain that area and get an overall view of what's going on in the extremity. So I had 15, 20 minutes, and I think I did pretty well for
You did,
all
Kevin.
that.
Right on. I appreciate it. Thanks so much for walking through that. I guess
Thank
Kevin
you.
says, really no comprehensive imaging modality at this point, but really complementary and helpful to have all modalities. So please feel free to put any questions in the Q&A, and we can address those at the end. But we're going to switch over to Kathy and Katrina to walk us through a couple of cases where, from a therapy standpoint, imaging was helpful in guiding management.
So I'm going to share my screen.
Great.
Am I sharing?
Yep, looks
okay.
good.
Thank you. I'm Kathy Shula. I'm one of the lymphedema therapists here at the Boston Lymphatic Center, and with me is Katrina Janksy, who is another lymphedema therapist. I'm a physical therapist. She's an occupational therapist. And I thought what we would do is just give you some examples of how we would use the imaging to help us with our decision making. Really, it's not going to take the place of our decision making, but it really does help us have a little bit more confidence in some of the decisions that we're making, and it will give us a little more freedom to push a little bit harder, to be more aggressive in making some decisions about compression than we otherwise would be able to do if we just were relying on our physical exam. So 4 examples of when we're using the imaging to help really reinforce our decision making is with preoperative, we call it optimization of the patient's edema control before they head into any type of surgical procedure. With ICG guided MLD, also managing compression after surgical procedures like the surgical debulking and the lymph node transplant. So part of the decision-making process, really, we work as a team, which is why we're using the results from the imaging in our decision-making, because we have access to this and we make decisions, shared decision-making as a whole team. As a patient comes into the vascular medicine clinic and they're determined to have lymphedema, we're asking questions about whether or not the conservative therapy has been optimized. Have we done everything we can do conservatively before they proceed to surgery? And if not, we have another round of conservative treatment. If so, they proceed with the rest of the workup, which would include all of the diagnostic imaging, and then we meet at a weekly basis at our conference and talk about this. And we've talked about this at previous webinars, our process. So we're looking at the images in this context. So one of the ways we use the MRI information, once the patient is determined to have lymphedema and they're either identified as being fat dominant, meaning they have a lot of fat hypertrophy as their main contributing factor to the volume difference, or fluid dominant. It really would set up the decision making to proceed with one type of surgical intervention versus another. But we're looking at how much fluid they have on board that needs to be controlled before their surgery. And we use kind of a 1 to 2 millimeter of pitting edema as our threshold. If they're more than 2 millimeters of pitting edema, then we really want to increase the edema control before they head into any kind of surgery. If somebody is fat fluid dominant and they have more than 2 millimeters of pitting, we really want to increase their compression. Now, if I hear from the radiologist that they have a moderate amount of fluid, or they have a moderate amount of fluid in the lower extremity and minimal fluid in in the lower leg and minimal fluid in the thigh, then we might take a more aggressive approach in adding compression in the lower leg, maybe not as aggressive in the thigh. So it might be changing the type of garment that they're wearing to address where the fluid is the worst. And it will also make, if somebody has a significant amount of fluid on board, according to the MRI, we're going to be very aggressive in adapting the compression. And if somebody is determined to be fat dominant, meaning they have a lot of fat hypertrophy as the main component, but they may also have some edema as well, more than the 2 millimeters of pitting edema on exam, but the MRI shows that they have a moderate amount of fluid on board as well as the fat hypertrophy. Knowing that we're going to have patients as part of our post-op protocol wear flat knit garments, and in the lower extremity they wear a significant amount of compression, 2 layers of compression garments in flat knit day and night. We might go ahead and order a set of flat knit garments for them to wear preoperatively in hopes of getting more containment of the edema before they proceed into their surgical debulking. So how aggressive we are really depends on not only our physical exam, but how much the radiologist tells us that volume difference is fluid versus fat. And then we heard about using ICG, and it helps us then to determine where to direct our energies in using manual lymphatic drainage. Because using this pattern, as Kevin mentioned, we have a nurse practitioner who is doing the injection and running the camera and doing the ICG lymphography, along with the physical therapist who comes in and then also helps to map out where we see these vessels, where we see most of the dermal backflow. So then we can give a map to the patient where to direct their energies when doing self-MLD or the therapist doing MLD. The direction of movement, which drainage nodes we want to push towards. So that's helpful to give a patient a map. So we would use it in that manner. After somebody has had a workup, a surgical procedure after a surgical debulking, and they proceed to a year after surgery, we're repeating the workup, we're repeating the MRI, we're repeating the lymphoscintigraphy, and that gives us some insight into how well the patient is been able to maintain. Do we see an improvement in the MRI? In other words, is there less fluid on board now after a surgical debulking? We would expect to see much less fat hypertrophy because all the fat has been removed. But do we also see a reduction in the amount of edema? Has the patient been able to maintain that edema control over the course of the year? And we want to make sure we're not seeing any worsening. The worst case scenario, we see more fat hypertrophy, which would really make us redouble our efforts in containing with much more aggressive compression. So we're using our physical exam, we're using our measurements, volume difference, lymphoscintigraphy, volume difference, bioimpedance, the amount of pitting edema somebody has, but also looking at the results of the MRI and the lymphoscintigraphy to help reinforce our decision. And it might be that we're being very aggressive based on what we find on the MRI. And then we also repeat the workup after patients are having a physiologic procedure. One example would be a lymph node transplant. And we would not begin to wean the compression until the patient has been out of surgery for at least 1 year. And we know over time, when that lymph node transplant becomes more effective, sometimes it will be several years before we see peak effectiveness. So we start the weaning process at 1 year, and we usually wait until that workup is done again. We would like to see the lymphoscintigraphy and the MRI, make sure that we don't see any worsening of symptoms. If we start to see some improvement, that gives us the green light to go ahead and start reducing the amount of compression. Usually we start to reduce the number of hours in compression, and I believe we had discussed this a little bit more in length at a previous webinar. But we would start to reduce the number of hours in compression and then follow with our physical measurements to make sure that the patient has been able to maintain that. But I think that looking at the imaging gives us a little bit more confidence to be able to give the patient some peace of mind. Yes, you look better. The imaging looks better. We're safe to go ahead and start to reduce the compression without fear of progression of the disease. So I don't know, Katrina, if you have any thoughts to add about decisions that you've had to make with patient and how you've used the MRI and the lymphoscintigraphy to help you support that.
Yeah, I think just to echo with what Kathy said, I feel like our exam with the bioimpedance and volume definitely can help guide us. And I think the imaging just kind of helps like further, makes us feel more confident in like what like our thoughts are from our evaluation or our follow-up visits. So it's just nice to have that like extra support and to kind of just feel validated in what your decision making is. So it's definitely helpful to and make us feel more confident and especially with like a wean of compression, which can be scary for you as a clinician or especially for a patient who's been wearing compression for years and years. So it definitely helps to have that as kind of an extra objective data.
And I don't know if we have any questions from any of the audience members, either for Kevin.
Let's see. So Angela asked, you mentioned bioimpedance. How is it used in evaluation and treatment planning? And then second question was, when do you start to wean compression after an LVA? So kind of two separate questions there.
We use the bioimpedance as part of our baseline measurements for all of our patients, and we're looking at the percentage of extracellular fluid in one limb compared to the other, or sometimes in one limb compared to the rest of the body. And if we see that excessive extracellular fluid, then that will tell us that we have to be a little bit more vigorous in our compression. We also compare that to the amount of volume change. So if we see a little bit more excessive extracellular fluid, we might pull in the compression or increase the number of hours in compression. We also start to see a volume change in addition to the amount of extracellular fluid. We're really going to be more aggressive in that. And after a lymphovenous bypass, when we start weaning from compression is definitely more individualized depending on the severity of the patient's disease, how many targets were bypassed, and where, how localized it was, whether it was lower leg that was targeted. So it's a lot of individual factors come into play when we start to wean for lymphovenous bypass as opposed to the lymph node transplant. It's not as standardized.
And just to add to the first question, I would say that we also will do it every time a patient comes. So like if we give any recommendations on like, let's say they need CDT or, we're changing up their compression, we always like to do this again. And there's usually a decrease in the number. So it's kind of also just a nice tool to have to track progress. And typically if the volume decreases, like the bioimpedance will also decrease. So it's just kind of nice, again, to have like some more objective data, and also great for like the patient to see, especially just like a visual image to see that like the work that they're doing is really paying off and that there's improvements that can be made.
And we do get serial imaging on these patients post-operatively, so that can help guide a little bit too in terms of when to wean. How does the edema look on follow-up MRI, along with the serial measurements that they're getting very frequently. So then Paul asked, does insurance cover imaging even treated conservatively? It generally does, Paul. We use lymphoscintigraphy. I see patients as a vascular medicine doctor on the front end, so 90% of our patients don't get surgery. So we'll use lymphoscintigraphy if we're having trouble with the diagnosis, if there's not an obvious prior lymphatic insult, If there's a question of primary lymphedema, just to really nail down the diagnosis, we'll often do it. Or if they're having edema for unexplained reasons, we'll do it to see is there a significant lymphatic component. It's almost always covered by insurance. If we start doing a high frequency ultrasound or ICG, that's more part of the surgical program or preoperative evaluation, but occasionally we'll do ICG and it's covered through kind of like the clinic visit. And then MRI is sometimes a struggle, but I'll say generally once we do the prior authorization in a peer-to-peer, we can explain why we would like to get it done, and it's usually not an issue. And then we'll take this as the last question because we're about out of time. Angela asks, how long does the lymphoscintigraphy imaging study take for a lower extremity lymphedema patient? Kevin, I'll let you answer that.
Yeah, so the patient comes in and we do a little, clipboard stuff, and then they bring them back and we inject them with the tracer. The injection takes, 5-10 minutes or so. And then we have them do exercises, especially with upper extremities. We have them squeeze a ball, move their arms around. That just takes a minute or two just to get the lymphatics flowing. And then we start doing imaging. And we can do spot views. We can do whole body sweeps that you saw that includes the whole limb. That may take 15-20 minutes or so. And then we get them off the table. We have them walk around, use their extremities, and then we bring them back at 2 hours and image them again to see how much stuff is how much flow has happened in that 2 hours or so. So we think about 2.5 hours for the procedure. Sometimes we ask for special views, which might add another 10-15 minutes on it. But yeah, we have to let people know ahead of time. It's not like a chest X-ray. You don't come in, we take a picture, and then you go. It takes a while to figure out what's going on.
And I'll always caution patients that though it takes 2.5 hours, they're not in the scanner. It's not like an MRI where they're stuck in the tube for a prolonged period. It's, they're kind of in and out of the actual imaging. It's just more the whole process can take that long. All right, well, we'll wrap up there. Thanks so much, Kevin, for joining, and Kathy and Katrina. We will send out an email in a month or two about the next webinar. And as usual, please feel free to reach out directly with either questions or ideas for future webinars. We're happy to take
Thanks,
any
Brett.
recommendations. Thank you. Have a good afternoon.